Your first presenter is Dr. Kelly Corbitt. She's currently an assistant professor of clinical medicine at the University of Miami. She completed her internal medicine residency and a chief resident year here at the University of Miami prior to doing fellowship training at New York University. Since returning as faculty member, Dr. Corbitt has helped to open a combined rheumatology interstitial lung disease clinic serving complicated patients with connective tissue disease related ILD. She has a strong passion for clinical care and is also highly involved in teaching from the medical student level, where she serves as course director for the musculoskeletal unit to resident and fellow teaching during clinics and consults. Please welcome Dr. Corbitt.
Thank you, guys. Okay, so for purposes of internal medicine, going through this topic, decided to take a bit of a bird's eye view here and look at kind of the complexities in caring for our patients with connective tissue disease-associated ILD, the things we take into consideration, and how we kind of manage this. At the end, I'll take you through one very complicated case that some people probably listening or here have helped with, a bunch of people have. Multidisciplinary care here is really important. So very briefly, interstitial lung disease or diffuse parenchymal lung disease is a heterogeneous group of diseases that affect the lung parenchyma and cause restrictive lung disease, and then they cause very kind of named out specific patterns on your CT. That's when you see your NSIP or UIP, those kind of patterns. Connective tissue disease, ILD, is a group of diseases within that broader ILD category that is due to dysfunction of the immune system. I named some of these here, kind of from systemic sclerosis down to lupus, with vasculitis and lupus not being as common as the other ones, and there being a whole group here that I left off called autoimmune or interstitial pneumonia with autoimmune features, or IPAF, and that is when you don't quite have an autoimmune disease, but we still think that your connective tissue disease is related to, oh, this was happening to me this morning too. It is not clicking forward. Related to the immune system. All right. So this is heterogeneous. There's a lot of different diseases here that kind of end up in getting interstitial lung disease, but our approach to treatment is somewhat homogeneous. So when we look at the American College of Rheumatology guidelines for the treatment of ILD, which are finally newly published here since 2023, you can look and you're seeing basically the same things, with the exception of tocilizumab and systemic sclerosis. Mycophenolate across the board is what we're looking at. Azathioprine, which we still see here in systemic sclerosis. Rituximab, Cytoxan, doesn't really matter what we're looking at. We're getting sort of the same thing here. And the steroid recommendation against steroids and systemic sclerosis is because you have a risk of inducing renal crisis with systemic sclerosis when you give steroids. I don't know if this clicker is just not going to work today. I might have to click from here. Let's see. No, it won't go forward. Oh, there we go. Okay. Not sure what's happening with the clicking. All right. So even when the disease becomes a little more complex, we're still looking at a relatively homogeneous view of what we're treating. So whether this is because they all share a similar pathogenesis, or whether this is because we don't know the nuances of the pathogenesis well enough to really tease these out, is not so well elucidated at this point. Okay, working now. Great. Thank you. All right, so you can kind of see here minor differences between these, but again, we're using a lot of the same kind of processes here. I don't know. No, it's still not. Maybe that's what I'm doing wrong. Usually in the morning, it doesn't do that to me. Okay, thank you. So how does this occur? So we kind of know that there's some mechanism that leads to fibrosis in these patients. And with autoimmune disease, we think cellular and or humoral autoimmunity kind of contributes to this. But there can also be endothelial cell dysfunction. You could be smoking, have infection. There can be activations of the macrophages for different reasons, formation of granuloma and something like GPA. You could have chronic microaspiration, especially in things like systemic sclerosis, where the GI tract is really involved. But regardless of the cause of injury, there's going to be some degree of inflammation And the body is going to want to try to heal that. And in the healing process, we end up getting into a paradox. Now, I don't know. It just keeps opening up things on here. All right, I'm just going to use the keyboard for this. We end up getting into this paradox where we're in a vicious cycle of kind of disruption of the balance. So I made this, nice little figure here in PowerPoint myself to sort of explain what is going on. So in general, in any tissue in your body, and the same holds true with the lung, you're in like a scale. You're in a balance between injury, inflammation, things that naturally happen in the body, even like air pollution, all these things, and healing and fibrosis. And in a perfect situation, this stays somewhat balanced. So you get inflammation, you heal it, you go back to normal, it happens again. You don't have too much of one side or the other. But in connective tissue disease, ILD, for some reason, you end up tipping the scale, and eventually this healing process leads to abnormal fibrosis. And so sort of what can happen is even when you get inflammatory mediators, we know IL-6 is big in systemic sclerosis, less so probably in some of the other diseases, then instead of giving an apoptotic signal to your fibroblasts, which are the cells that then go ahead and end up turning into myofibroblasts, lay down an extracellular matrix and cause scar or fibrosis, it actually starts giving an anti-apoptotic signal. So it makes these fibroblasts live longer, they turn into the myofibroblast, and then you end up getting this scar over time. So why do they get these inflammatory signals? It happens from a bunch of different regions. The macrophages have two kind of phenotypes here, one that's pro-inflammatory, one that's healing or fibrotic. They start releasing different signals due to whatever underlying cause is happening. Your B cells can start inducing antibodies, cytokines that can activate these macrophages. Your T cells, you end up getting more cytoxic here, but they also have a pro-fibrotic and an anti-fibrotic balance that gets disrupted. We start recruiting cells with these cytokines from the periphery. Vascular smooth muscle cells, blood monocytes can come in and actually turn into fibroblast. And then your neutrophils, from an innate immune standpoint, will start producing these things called neutrophil extracellular traps, which is basically like the debris of a dead neutrophil, and it tries to wall things off, but in doing so activates fibroblasts, activates the healing, you get more scarring and fibrosis going on with this. So it's a very complicated process that we're going between here. I hope this is easier for the next person. So why is it so difficult beyond, the pathogenesis that we just kind of broadly took a bird's eye view at? Well, there are differences to these diseases, but like I showed you in the beginning, we don't have a good understanding of the differences really within the lung. We try to extrapolate data from other studies. So if I have somebody with myositis or somebody with systemic sclerosis or rheumatoid arthritis, I might try to pick things that we know work well within those disease processes as my first or second line, or how we decide to move between these treatment options that we have within the world of rheumatology. The studies that we have on connective tissue disease, ILD, often combine a bunch of these diseases into one instead of really studying a singular disease, with the exception of systemic sclerosis, which is a lot of times studied by itself. But even things like myositis-related ILD, we know MDA5, antisynthetase syndrome, these are different disease processes. So studying them all together, again, is a little bit challenging. And then we don't really understand why acute exacerbations occur, but the mortality rate in some studies is as high as 100% when somebody exacerbates and gets admitted. So this is something we want to prevent, and we think that it's a combination of both disease, the active autoimmune disease kind of triggering this, and in some people, infections. But because we don't know that pathogenesis too well, it becomes very challenging and difficult. So what's our general goal in management? Do we want to improve them, stabilize them, transplant them? This is kind of the way that I think about it for most of my patients. If they have progressive connective tissue disease despite the initial therapy, a lot of times we want to keep them stable. If we can improve them in the beginning, if they're more inflammatory, which some of these patterns are, great, improve them, have them live their lives. Obviously, lung transplant has its mortality too, but if they're progressing despite treatment, I kind of want to stabilize them so that we get to transplant as calmly and easily as we can. And this is a danger zone to me where they could end up hospitalized, get too sick, need to delist, and then that's, or never get listed in the first place is really how I should put that. And then that would be a big issue. And things that we consider when we try to personalize this is what's a suspected mortality. So connective tissue disease mortality from rheumatoid arthritis is about 8%. From systemic sclerosis, closer to 40%. So depending on the disease process, you may be more or less aggressive. What extrapulmonary manifestations are we dealing with? What are the joints doing? What's the skin doing? What's the GI tract doing? Depending on, the disease process. Is the lung more inflamed, or is it more scarred? Should I be very aggressive up front if it looks like something like organizing pneumonia is a very inflammatory pattern that we see that may be more responsive to strong immunosuppression when you're weighing like infection risk versus risk of the disease acting up? And then what's the likelihood of transplantation success? So while we kind of use idiopathic pulmonary fibrosis as the guideline here, like the success of those patients, how do connective tissue disease do comparatively? And it seems to be about the same, but you have to take into account what the extra pulmonary manifestations are, how active that disease is. And then we'll mention it in the last slide here, but then there's some nuanced things where people may actually do very poorly with lung transplant. And then that would be a different situation where we want to be very aggressive outside of transplant. So a big thing for internal medicine, recognition. If somebody doesn't notice they have this stuff, it's going to be progressed by the time they even come to see me, they see pulmonology, they see everyone. So being aware of these diseases and being aware these diseases also affect the lung is really important. Treating early is very important too. So if you look at any of these studies where we see kind of how do we do when we treat people with connective tissue disease related ILD, it's mostly that we're trying to take a downward slope and even it off. We're not often turning them back around completely. We're kind of stopping progression. So treating early, and then I say reasonably aggressive, depending on the patient's individual disease, all those things we just talked about on the other slide. Multidisciplinary care, super important. And then minimize steroid use. So we love steroids, and sometimes people think steroids are less dangerous than our other immunosuppressive agents that we give. I see this a lot in the hospital, especially when people get admitted. And I also see this just kind of from PCPs in practice that'll keep people on steroids and not really have much urgency to get them in because they're doing fine on steroids and, whatever. But there was this interesting study that looked at 150 connective tissue disease patients, and they looked at two things: risk of progressive fibrosis and risk for increased mortality. Elevated CRP, which they attributed to the underlying autoimmune disease not being well enough controlled, was a risk factor for both. Fibrotic, of course, rather than inflammatory, bigger risk for fibrosis, but not having that at the baseline was a risk for mortality, but progressive fibrosis was, either due to a disease not fully being treated or whatever that may be. And then really interesting here, steroid use was a risk factor for both progressive fibrosis and increased mortality. And if we had more than 30 minutes, I could explain the theories behind that. But when you look at this with mycophenolate or with other immunotherapy, that was not a risk factor for increased mortality or progressive fibrosis. So steroids are actually independent of this, whereas other immunosuppression, it isn't the same thing. And it was a dose effect here. So the higher doses is going to be more of an increased mortality than lower doses. And they did look at the steroids to see if sicker people were getting steroids, and that wasn't the case. It was pretty even between the two groups. So it didn't have to do with how sick somebody was. All right. I'm kind of going to show a slide or two about general treatment stuff. So both of these studies, you have one study from Lancet here on, I guess this is the left of the screen. And then you have another one on the right. These are both combined connective tissue disease ILD patients, so with multiple different causes of their disease. And I wanted to point out a couple things. So this is pretty typical, where when we look at things like Cytoxan, rituximab, we think of these both as major things. They're non-inferior to each other, but most studies are sort of like this, where Cytoxan wins out a little bit by numbers alone, but statistically ends up being non-superior to rituximab. But I like to point out, even though Cytoxan definitely has more side effects, infections not so much. So the percentage of infections from Cytoxan was 8%, from rituximab was 10% in this study. So we do in general think of rituximab as a less dangerous drug, and it's true, but it may not really be always just the infectious risks that we're looking at there. And then this study on my right was looking at NSIP from any type of autoimmune cause. And it combined rituximab with MMF, so using dual immunosuppression together, and they found that there was a difference. Those on dual immunosuppression did better than those only on MMF without rituximab. And what's really interesting here is, although there was more infection, 14 versus 7 in the combined group, which was led by viral infection, there was no difference in bacterial or fungal infection between these two groups, just virus. There was much higher problems from the underlying lung disease, 20% versus 5% if you didn't treat. So looking at this, you're having more exacerbations if you're holding back immunosuppression in this group versus actually treating. So it's a bit of a trade-off here. Now, MBDA5 rapidly progressive ILD, which comes from a form of dermatomyositis that's very aggressive, is, I put down here, its own beast. But you can see here, we actually suggest combining immunosuppression out the gate, because if you do step-up therapy, meaning you add as a patient gets sicker, the mortality, really falls off here, which is the graph on the right that you can see. And I put these predictors of mortality, so elevated ferritin, elevated LFTs, elevated LDH, CRP, lymphopenia, older age, concurrent Rho52 antibodies, and being male, all make it more likely that somebody is gonna die from this disease. We'll kind of get into that. Oh, and with this combined therapy of Cytoxan, tacrolimus, and IV steroids, there were more CMV reactivation, but no differences in bacterial infections between the groups. So again, even though we're doing a lot of immunosuppression out here, it's mostly the viruses that are the biggest issue. So could it be that with everything I just said makes mortality higher? Sounds a lot like HLH or MAS. So, and we do see secondary MAS or HLH in these patients. So could it be that rapidly progressive ILD and MDA5 dermato is akin to ARDS from macrophage activation? So we think there's a couple reasons that this theory may be true. And like I said, MDA5 does get full-blown, meets criteria for macrophage activation often when they have this phenotype. But basically, they're both thought to be due to a viral trigger. You essentially get this virus-infected cell, and then T cells and NK cells, which are supposed to get rid of that cell via a very non-inflammatory way, have ineffective apoptosis for, reasons underlying the disease that we can't get into. So then what happens if they can't kill a cell, then a macrophage comes in and does something called lytic cell death. When it does that, it releases a whole bunch of pro-inflammatory cytokines, but then also these infected cells release all their contents, and you get this innate immune system cytokine storm situation, and that's mostly driven by this cytokine called interferon gamma here. So there were a couple studies. One showed that autoreactive B cells and severe MDA5 dermato directly stimulated interferon gamma, so maybe even without an effective apoptosis, this is occurring. Another study showed it was the only cytokine to actually correlate with ground glass opacity on CTs. And then there's been some autopsy studies that have shown lung tissue stains very heavily for interferon gamma positive histiocytes, as do the hilar lymph nodes. So we'll do a couple sides of a case and we'll be done here. I apologize for all the text on this slide. This is a very complicated patient of ours, but I will sum it up. So this was a 54-year-old lady that had a past medical history of hyperthyroid, was otherwise well until November of 2023. She got gum swelling, a photosensitive facial rash, and then she ends up getting the severe hepatitis. LFTs are, her liver enzymes in the thousands. She had severe hyperferritinemia greater than 10,000 at one point. She was admitted 3 times at Jackson, at UM, and at an outside hospital without clear showing of what she had. There was some concern for viral infection at some point. She got acyclovir. There was some concern for HLH at some point. She got steroids. But then they came in and said, no, I don't really think this is happening. So she kind of got these like intermittent bursts without much going on. But then she was referred to pulmonology because her CT chest had some abnormal findings, and she was found to be MDA5 and Rho52 positive. Formally diagnosed with MDA5 dermatomyositis, admitted back to UMH. She was incredibly weak. She was in a wheelchair when I met her in my clinic. She couldn't swallow. We did a bedside swallow. We admitted her right back to the hospital. Interestingly, this can happen with this disease where you have normal CK levels and still a myopathy. She did have Gottram papules on her elbows, but not on the rest of her changes. And she had these vasculopathic changes on her fingers. So from those mortality predictors we noted, she actually had 7 out of 8 things that should say she should not make it. So what happened? So kind of going from the left of the screen and down, there's dates on here. Pre-diagnosis, this is when she gets sent to pulmonology clinic, and she has some stuff there, but the lungs overall don't look too bad. Then she gets admitted on like 5/6. She starts getting treated by 5/25. Lungs still don't look too bad, but they're starting to get a little bit more consolidation in there. She's getting steroids, cyclophosphamide, tacrolimus. At some point, got all of these things, IVIG, Plex, anakinra for her, the MAS type component, and then JAK inhibitors, ruxolitinib, and then tofacitinib at some point. So got every treatment under the sun for this. And then on 6/29, she was developing more of a oxygen requirement. She was developing more respiratory symptoms, these horrible coughing fits. And we re-CT, and through all of this treatment, she's just developing more and more consolidations. So call ID, say, please bronch this lady, and they bronch her, and there is nothing on the bronch. It is just the MDA5, and they send for everything. So then we end up adding emapalumab, which is an interferon gamma inhibitor that has approval for HLH and has studies in MAS right now. And then after addition to that, these opacities that we couldn't clear with anything else started actually clearing. And you can see, especially on the one side, this is a little bit about a month in between. And so this is the first time I'm aware this has ever been shown in MDA5. We're going to publish this. So we did that. She did have a complicated course because she's also had pneumomediastinum, which was severe and spontaneous. She was admitted for a month where we kind of had to wait that out with a chest tube, and she ended up getting a blood patch. But then that completely resolved too, and she overall did well. She is at home, and she's doing really well. She is a patient of mine that has my cell phone, so I'm very aware of her. But she's improving. She's working with PT. She feels better, and her labs in general, both her IL-2 soluble receptor level, which is a marker we use sometimes for things like MAS, is improving, and her MDA5 antibody level, which we can sometimes see turn negative and we think has to do with this pathogenesis, is also improving. So what about lung transplant? So it's an option down the line if we need it, but the ideal situation with this type of rapidly progressive ILD is to get a patient stabilized and quote unquote chronic, and then transplant later if necessary. There were these 2 studies that while connective tissue disease ILD performed the same with lung transplant related to IPF patients, the survival with these type of rapidly progressive dermatomyositis related ILD patients did not do as well. So they're the green line on there. And this is basically if you looked at patients trying to transplant these patients in this acute type of status. But a similar study showed that if you got them, if they ended up being chronic, and this isn't perfect because some of these patients in a chronic state don't have that severe phenotype we looked at with her. But if you can control this initial situation, then they do very, very well with transplant down the line, but just not up front. So I think that concludes my presentation. We have a combined clinic. Please send us patients. Dr. Varghese is also here in the back, and I will take questions.
Thank you, guys. Any questions from the live audience or comments? Dr. Punjabi has a question. Go ahead. I can say it. I can.
Great talk, Kelly. Thank you for that. What's going on in the genomic proteomic world to understand what the underlying MDMA pathogenesis and treatment options could be done in the future?
Thank you. So that's a great question. Not a whole lot yet is the answer. I think in writing this stuff, because we're kind of in the realm of doing some work publishing this now. I've read a ton of papers on this, and including its pathogenesis, and I haven't seen a whole lot. Where this focuses on other connective tissue disease related ILD patients is more looking at sometimes RNA-seq data saying, okay, what cells might be the most pathogenic here. This is really where we get IL-6 and systemic sclerosis, even outside of the tocilizumab study that came out, and then Th17 cells in rheumatoid arthritis. And then we did see CD8 positive cells, which we think are a reason for the interferon gamma in MDA5, but RNA-seq data on CD8 positive T cells was like really the only thing I'm seeing if you're kind of going in that realm. But otherwise, I haven't seen too much out there yet.
Can you make a quick question?
So I know like in IP, or I read a long time ago in IPF, they use these anti-fibroblast medications, or like, I want to say like pirfenidone, I don't remember. Have they ever been used in combination with the immunosuppression for?
Yeah. So they definitely are, and it depends on the disease. So they've been studied in things like systemic sclerosis related ILD and in some of our other disease processes here. But adding them, it depends on what you're doing too. So like the patient I just showed you with the MDA5 is like a lot of consolidation. She has a kind of a pattern that looks like something called organizing pneumonia. She's very inflammatory. So a lot of times those are added after the fact, or if somebody is more fibrotic, we can use them. And then it depends on the pathogenesis, because if we really think that the progressive fibrosis is coming from the immune response, we want to halt that immune response, make sure they're tolerating those meds, and then add them as we kind of can. But they can be combined and they can be helpful. They just have side effects too.
And maybe while the next speaker is getting ready, if you can, like in 20 seconds from the from online, why not use interferon gamma antagonists or monoclonals with steroids from the get-go if the interferon gamma is so high? Is that a consideration?
Well, like I said, so this is the first time this has ever been done in MDA5. It's been done in MAS, but and it's a very, very, very expensive drug. So I had to go meet with the CEO of Miami to get them to let me use this drug. And it's in the 6-digit range. So this patient had very clear MAS, as well. But we're going to see if we can study this, specifically in this disease with the lungs, and maybe we could use it earlier. Ideally, I mean, this was the perfect patient in the sense that she wasn't, now completely, on ECMO, intubated, everything else. And this is really probably where we need to intervene, because what we see happen in these patients without an intervention in her, if those consolidations had continued, we'd be looking at intubation probably within that next month, and then, not making it. But maybe that'll be something we can do in the future. Well, you will see. Yep.
Our next speaker is Dr. Varghese. He is an assistant professor of endocrinology at the University of Miami. He has a keen interest in building a clinical and research career in diabetes and obesity medicine, and in the treatment and management of complications arising due to these diseases. Recently, an integrated metabolic clinic for sleep disorders was started at the University of Miami as a collaborative effort between the divisions of endocrinology and pulmonary and sleep medicine. He is currently an endocrinologist involved in coordinating the clinical and research efforts in this area. Dr. Varghese completed his MBBS at Government Medical College in Trivandrum, India, and a postgraduate fellowship in diabetes from Christian Medical College in Vellore, India. He has also completed a 3-year postdoctoral T32 research fellowship in endocrinology from Mayo Clinic. The internal medicine residency was acquired from White River Center in Batesville, Arkansas, and his clinical and research fellowships in endocrinology from the National Institutes of Health. Dr. Varghese is board certified by the American Board of Internal Medicine in both internal medicine and endocrinology, diabetes and metabolism. He is a diplomat of the American Board of Obesity Medicine and has been elected to the fellowship of the American College of Physicians. Please welcome Dr. Varghese.
Thank you, Dr. Pudumana. Thank you for giving me this opportunity to present for the medicine grand rounds. I'd like to discuss on the topic of the role of obstructive sleep apnea in obesity and type 2 diabetes mellitus. So I'd like to start off with a case of a 61-year-old man with type 2 diabetes for the last 11 years. He suffers from symptoms of gastroesophageal reflux daily. He also has moderate depression. And for the last 11 years, he has been maintaining a weight of somewhere between 210 and 220 pounds. And his current BMI is 31 kilogram per meter squared. There's no history of essential hypertension or dyslipidemia. There's no other known complications of diabetes mellitus. And he's been managing himself with a low carbohydrate meal plan and an exercise regimen with a bicycle exercise program. He reports that he snores and reports being excessively sleepy all the time. He has no family history of any diabetes or sleep apnea. He's come here now because during the past year, he has been unable to have his plasma glucose levels less than 200 milligram per deciliter. And during the last 2 visits, his A1C has been 7.5%. He denies symptoms of polyuria or nocturia and states that he's in bed for about 8 hours per night. His wife does not complain of having noted his nighttime snoring, but she reports that she herself is a heavy sleeper and history may not be reliable on that front. He states that he's excessively sleepy, yet he claims that he sleeps 8 hours per night. Colleagues and family of his who have slept in adjacent rooms have told that he snores and gasps throughout the night. So essentially, this is a patient who is most likely having obstructive sleep apnea. So with this, I'd like to go over this presentation with the following objectives to define what's obstructive sleep apnea, to try and understand how obstructive sleep apnea and sleepiness contributes to worsening of glycemic control, and how the treatment of obstructive sleep apnea affects glycemic and lipid profiles, and what about weight loss with lifestyle modifications and new medications for weight loss, including GLP-1 analogs. How does it affect obstructive sleep apnea? So obstructive sleep apnea is a decrease or complete cessation of airflow despite an ongoing effort to breathe. The patients often have loud and frequent snoring. They also have choking, snorting, or gasping sounds when the airway reopens after obstruction. And the disease-defining metric here is a measure called as apnea-hypopnea index, which is the number of sum of the apnea and hypopneic episodes that the patient has had per hour. And as you can see here, when the patient sleeps, the tongue falls backwards. So does the soft palate and the uvula. And this basically obstructs the airway. And that is what causes obstructive sleep apnea. So in this condition, the pathogenesis, there is an upper airway obstruction, which causes hypoventilation and then causes intermittent hypoxia onset. There are other factors like decreased airway size or the resistance and collapsibility of the upper airway that may predispose to intermittent hypoxia. So this intermittent hypoxia then causes a decreased ventilatory drive and decreased muscle tone, which causes decreased respiratory effort and causes increased carbon dioxide levels in the blood and decreased oxygen levels, hypoxemia and hypercarbia, which ultimately results in arousal of the patient with increased ventilatory drive and increased muscle tone, leads to the airway opening up and then causes hyperventilation, and the patient returns to sleep. Once the patient is asleep, again, the airway gets obstructed and the vicious cycle goes on. So this is how the patient goes from obstruction of the airway to opening of the airway and then back to obstruction of the airway again. The prevalence of obstructive sleep apnea increases with age and is higher in middle and older age group. About 24% of the men and 9% of the women have disordered breathing events of more than 5 events per hour. One of the common symptoms of obstructive sleep apnea is sleepiness, but of note, this occurs only in 4% of men and 2% of women. And again, 24% of men and 9% of women have disordered breathing events, but only 4% and 2% have symptoms of sleepiness. And this often results in about 80 to 90% of adults with obstructive sleep apnea remaining undiagnosed. Obstructive sleep apnea may also occur in children, and it's common at the preschool ages. And there are certain risk factors which adds on to the risk of developing obstructive sleep apnea. For example, if you're overweight or obese with a BMI of more than 25, that itself is an independent predisposing factor for developing obstructive sleep apnea. People with large neck circumference, which is more than 17-inch in men and 16-inch in women, are again at a higher risk of developing obstructive sleep apnea. As discussed, middle and older age men and postmenopausal women, because age itself is a risk factor. People who have abnormalities in the bone and soft tissue structures of the neck, and children with large tonsils and adenoids are also at risk of developing obstructive sleep apnea. Certain conditions like Down syndrome and endocrine disorders like acromegaly and hypothyroidism also predisposed to developing obstructive sleep apnea. If a person has a family history of obstructive sleep apnea, that itself is a further risk factor for developing obstructive sleep apnea. So the risk assessment of obstructive sleep apnea is used. There is a tool that you can use. It's called as the Stop Bank score. So there are different items, 8 items in the score group, and each item has a score of 1. And a score of more than 2 to 4 basically puts you at an intermediate risk of having obstructive sleep apnea. And a score of more than 5 puts you at a high risk of developing obstructive sleep apnea. And it's basically a mnemonic: S for snoring, T for feeling tired, O for having observed apneic episodes, P for high blood pressure, BMI of more than 35, age of more than 50, neck circumference of more than 17-inch in men and 16-inch in women, and a male gender. So if you have more than 5, there's a very high risk of having obstructive sleep apnea. The disease severity of obstructive sleep apnea is quantified by the apnea-hypopnea index. And this is a sum of the apneic and hypopneic events that occur per hour. Up to 5 events per hour is within the normal range. If you have between 5 and 14 events per hour, it's in the mild, it is classified as having mild obstructive sleep apnea. Moderate sleep apnea, pardon me for the typo, it's 15 to 30 events per hour. And if you have more than 30 events per hour, it is severe obstructive sleep apnea. So there are several conditions that predispose or worsen obstructive sleep apnea, including short sleep duration and circadian misalignment, besides obstructive sleep apnea itself, which causes sleep fragmentation and intermittent hypoxia. This activates further hormones downstream. For example, both sleep fragmentation and intermittent hypoxia causes sympathetic activation, leading to increased catecholamines. The cortisol levels that are supposed to dip when you're sleeping may not happen because the sleep is disturbed, and this leads to increased cortisol, and thus the HPA axis is also affected. There is hypoxia followed by rapid oxygenation, which predisposes you to have oxidative stress and have increased reactive oxygen species. There are also pathways of the inflammatory pathway, including interleukin-6 and TNF-alpha that's activated due to these reasons. And also increased leptin and adiponectin, which are adipokines that are affected on account of obstructive sleep apnea. All these factors result in insulin resistance and also decreased insulin secretion from the pancreas. So it's a double whammy. Basically, insulin resistance and insulin secretion are affected, both of which predispose you to develop glucose intolerance and type 2 diabetes down the lane. So as discussed, the intermittent hypoxia causes several mechanisms, including sympathetic activation, inflammation, and oxidative stress. And this can affect different organs. For example, at the level of the adipose tissue, it can cause inflammation, insulin resistance, and increased lipolysis, leading to increased free fatty acid production from the fat tissues. At the level of the liver, it can cause increased fatty liver or steatosis of the liver, increased inflammation, and increased glucose production from the liver. At the level of the pancreas, it can cause decreased insulin secretion and also beta cell dysfunction. At the level of the muscle, it can cause decreased glucose uptake, both due to the intermittent hypoxia and also because of the fact that there's an alternative substrate in the form of free fatty acid. It also has been reported to alter the composition of the gut microbiome, and also there is increased leptin resistance at the level of the brain. So all these factors cause insulin resistance, glucose intolerance, and thus type 2 diabetes down the lane. So basically, obstructive sleep apnea affects both insulin secretion and insulin action. There are three mechanisms at the tissue level that can cause predisposes obstructive sleep apnea to worsen glucose metabolism. So the first is that there is intermittent hypoxia and sleep fragmentation, which can activate the sympathetic nervous system, and that itself can cause the effects that I just mentioned. The hypoxemia followed by rapid reoxygenation increases the production of reactive oxygen species. This is similar to what has been observed with ischemia reperfusion injury. And ROS basically also increases the transition from prediabetes to diabetes. There are also markers of inflammation and adipocyte-derived inflammatory factors like IL-6 and adipokines that have also been implicated in the pathogenesis. So the treatment of obstructive sleep apnea is with continuous positive airway pressure. So this is a CPAP machine which basically delivers oxygen at a high pressure, and that basically opens up the airway, thus taking care of the issue of obstruction of the airway, which downstream leads to the clinical manifestations of obstructive sleep apnea. One of the common symptoms of obstructive sleep apnea is sleepiness, and this is quantified using the Epworth sleepiness scale. This is a scoring scale which has 8 items. Each of the items are scored from 0 to 3, and you just add up each of these scores. And basically, if you have a score of 12 or more, that predisposes you to be at a higher risk of sleepiness secondary to obstructive sleep apnea. So there was a study done by Dr. Punjabi and group where they tried to find out the role of sleep apnea, sleepiness, and glycemic control in type 2 diabetes. And they were trying to find out the association between glycemic control and sleepiness in people with obstructive sleep apnea and type 2 diabetes. They used self-reported sleepiness and glycemic control in moderate to severe obstructive sleep apnea, and they found that it varies as a function of BMI and sex. So when they stratified by sex, sleepiness was associated with a higher HbA1c level, but this finding was clinically and statistically significant only in men with a BMI of less than 35. They also found that the A1c levels were higher by about 0.5% in people who reported an Epworth sleepiness scale of more than 11 compared to those who had a lower sleepiness index. So basically, so this is basically a graph, the figure 1 on the left panel. It shows the Epworth sleepiness score on the x-axis and the A1c on the y-axis. And the group was divided into quintiles based on the ESS score. And though there was gradation that was seen depending on the ESS score, the difference was not statistically significant. However, when they were stratified by BMI and stratified by sex, you can see that in men, there was a dose-dependent increase in the A1c based on the quintile of Epworth sleepiness score the patient was in. So basically, in men with a BMI of less than 35, sleepiness does contribute to increased A1c levels. What about the effect of CPAP in other comorbid conditions? For example, there was a study that was published in NEJM where they studied patients who were treated for heart failure. And in them, the treatment of obstructive sleep apnea by CPAP reduced the systolic blood pressure and was also shown to improve the LV systolic function. So the authors report that obstructive sleep apnea may have an adverse effect in heart failure, which can be targeted by therapy using CPAP. Similarly, the question also comes whether treating people with oxygen instead of CPAP is helpful. So this study was published in 2014 in NEJM. So they took patients who had cardiovascular disease or multiple cardiovascular risk factors, and they showed that this treatment of obstructive sleep apnea with CPAP, but not with nocturnal oxygen supplementation, resulted in a significant reduction in the blood pressure. What about studies that compared CPAP versus weight loss versus a combination of both these factors? So this study was published in the NEJM in 2014, where they tried to, the study group was a population who had an HSCRP, a marker of inflammation, of more than 2. And these were adults with obesity and obstructive sleep apnea. And they basically showed that CPAP combined with weight loss intervention did not reduce the CRP levels more than either intervention alone. Although the study was not powered to detect the differences, a secondary analysis showed that weight loss provided an incremental reduction in the insulin resistance and triglyceride levels when combined with CPAP. And CPAP was shown to have an incremental reduction in blood pressure as combined to with either intervention alone. So basically, a combination intervention did not result in a reduction of markers of inflammation. Weight loss seems to be predominantly efficient in reducing insulin resistance and serum triglyceride levels, whereas CPAP seems to be additionally beneficial in reducing blood pressure. Now, this was a study that came out recently in June of 2024. It's the SURMOUNT OSA study where they tried to find out the impact of GLP-1 analog treatment in patients with obesity and obstructive sleep apnea. So the background was that weight reduction is a standard recommendation for sleep apnea treatment in patients with obesity and overweight. However, it is quite challenging to obtain weight loss without measures like bariatric surgery. At the time of the study, there was no medication for obesity, which was demonstrated to have an effectiveness in obstructive sleep apnea, and thus the study was warranted. And they done the study to study the efficacy and safety of tirzepatide for the treatment of moderate to severe obstructive sleep apnea in patients with obesity. So the study basically had two subgroups. The panel on the left is the study group which were not on CPAP, whereas the study group on the right is the group that was already on CPAP. Both the groups were randomized into either placebo or medication with tirzepatide, and the study went on for a period of 52 weeks. And again, the baseline weight was 114 kilos in both the study groups. And this graph basically shows the weeks of treatment with tirzepatide on the x-axis and the percentage change of weight from the baseline on the y-axis. So in the group that was not on CPAP, placebo over a period of 52 weeks resulted in a decrease of 1.3% in weight over a period of 52 weeks, whereas tirzepatide resulted in an 18% weight loss over a period of 52 weeks. In the group who were on CPAP, placebo resulted in 2.3% weight loss, whereas tirzepatide resulted in a 20% weight loss in 52 weeks. So with this weight loss, what happened to obstructive sleep apnea or the apnea-hypopnea index? So again, this is a graph that shows the weeks of treatment on the x-axis and the change in baseline events per hour of the apnea-hypopnea index noted on the y-axis. Of note, both groups had a baseline mean apnea-hypopnea index of 51.5. Again, just to put it into context, more than 30 events per hour is severe obstructive sleep apnea. So at baseline, these subjects had 51.5 events per hour from a mean perspective. And treatment with placebo resulted in a 4.8 reduction of 4.8 events per hour in the placebo group. But in the tirzepatide group, this resulted in a 27.4 reduction in events per hour. What about in the group that were on CPAP? Similar changes were observed. The placebo, there was a 6 events per hour reduction, whereas in the tirzepatide group, this resulted in a 30.4 events per hour reduction from baseline. So tirzepatide was basically shown to reduce both weight and also the apnea-hypopnea index, independent of whether the patient was on CPAP treatment or not. So this study brought a novel design to investigate if tirzepatide resulted in a clinical improvement in obesity-related obstructive sleep apnea by targeting the underlying etiology of obstructive sleep apnea, which is basically excess weight. So to conclude, I'd just like to reiterate that according to the American Academy of Sleep Medicine, about 80 to 90% patients with obstructive sleep apnea remain undiagnosed. Weight loss and treatment with CPAP would be key to reduce morbidity and long-term mortality, and also the quality of life of these patients. And sleep physicians and endocrinology working together with primary care would be a key to tackle the epidemic of obstructive sleep apnea. From a university perspective, we, under the leadership of Dr. Barnam Misahi and Dr. Punjabi, we have a new integrated clinic, which is operational for tackling both sleep apnea and sleep disorders and obesity. And we, in this clinic, both sleep physicians and endocrinologists work together to improve outcome and care for patients. This clinic is located at the Bascom Palmer, 5th floor in the sleep clinic office, and works on Fridays from 8 to 5 p.m. And we'd be happy to see patients in the clinic and help them out. I'd like to thank my mentors, Dr. Yacobilis, Dr. Galindo, Dr. Punjabi, and Dr. Bernal. I'd like to thank the endocrinology fellows and the staff in the endocrinology division for all help thus far. Thank you. I'd be happy to answer any questions.
Thank you very much. We have a few minutes for questions, comments. Dr. Punjabi, I know you have something to say. Yes, you do. Sleep and diabetes, it's like in your wheelhouse.
Ron,
Dr.
thank you for
White.
that, and nice overview of the topic. One of the challenges that we have in this field is now with the GLP-1s, the weight loss is so dramatic. The question is, what's the effect on airway function? I mean, airway muscle function, upper airway muscle function, independent of obesity. We know for decades, since the 1980s, that about 10 to 20% weight loss will lead to improvement in apnea severity. Now, the GLP-1s do something else. They actually allow you to lose weight, or they help you lose weight. But the question is there a direct effect of the GLP-1 on muscle function itself? I think it's important to know that these GLP-1 drugs have other effects. And the question is, if they have effects on muscle function, how do they affect the upper airway? If you could remove the effects of obesity, which is a very different question, right? The airway, I mean, you've shown, or at least the study recently from Eli Lilly showed that, yeah, you drop the apnea-hypopnea index substantially. It's not trivial, it's a substantial drop. Clinically even, not just statistically. The question is, are there side effects that are going to be created with a hypotonic airway if you were to think about continuing this drug on for a long time, and now you've got someone lean, but maybe has a recurrence of apnea, maybe due to impaired muscle function? Any thoughts on the effects of GLP-1 on muscle function?
Thank you for the question, Dr. Punjabi. Very interesting question. There have been reports that GLP-1 analog does cause muscle wasting or sarcopenia, but I'm not sure whether there are many randomized studies or anything to that effect, which clearly state the same. The thing is, if you lose weight, you tend to lose both fat mass and muscle mass. So with GLP-1 analog therapy, do you have more muscle loss? I don't think that question has been answered to the full degree with randomized studies. But independent of whatever method you use for weight loss itself usually results in both fat loss and muscle loss. There are recent studies which actually show that GLP-1 analog also activates the visceral fat, the metabolism at the level of the visceral fat. So that's yet another reason, and how it affects the muscle function is unknown. And I think studies are warranted in that direction.
Thank you. We have a couple questions online. There's an endocrinologist named Roy Weiss who would like to ask a question. Dr. Weiss, you want to unmute?
Yeah, I'm sorry I can't be there in person. I'm in this fabulous city of Athens, Greece, at a thyroid meeting, but wanted to comment. Both presentations were absolutely excellent, but I just want you all to consider one other metabolic derangement in sleep apnea that's well known, and that's cortisol perturbations. The fluctuations of cortisol levels, either primary or secondary related to sleep apnea, can have profound metabolic effects as well. And perhaps correcting that along with the other things might be one of the keys to understanding better treatment in sleep apnea. Have you thought about that?
Thank you, Dr. Weiss. Excellent question. In normal sleep, for instance, your cortisol is supposed to dip at night. So one of the tests we commonly use is salivary cortisol. You can see a gradient between morning cortisol and salivary cortisol in the evening. Now, what happens in sleep apnea is that when people don't sleep well, that dip in cortisol does not occur. So that has been shown in several studies. What impact it has on the metabolism is a very good question. I think it's a very good research question to ask for, especially long term. And the other question is, what does weight loss have? How does weight loss affect the whole picture? Specifically with GLP-1 analog therapy, does it change the cortisol levels? I think that's also something that's a very good question to ask forward from a research perspective.
Thank you. We have 2 minutes and 2 questions. So Dr. Chediak and Dr. Bernal, if you can maybe start with Dr. Chediak, quick question and maybe a 30-second response. If you want to unmute.
What was the effect of on blood pressure when you use GLP-1 without and with CPAP in the study you just reviewed?
Yeah. So GLP-1 analog usually has been reported to have a higher result in a higher heart rate, meaning tachycardia. But it usually, because of its effects on blood pressure, because of its effects on weight loss, it usually causes a decrease in the blood pressure. But off the top of my head, I don't remember from the study exactly what the differences were. But yes, it did result in a decrease in the blood pressure.
And Dr. Bernal?
Thank you, Ron. Just related to a question from Naresh. Is there any evidence of GLP-1 receptor analogs directly acting in respiratory muscles? Because we know that they can cause sarcopenia, but is there any effect on respiratory muscle?
Thank you, Dr. Bernal. Yeah, to the best of my knowledge, there have not been any studies that specifically address that question. And so I think it will be a good question to ask looking forward as a research question. But also, whether there are any deposits of visceral fat around the neck area. Like, for example, Dr. Yakovlev does on epicardial fat. Are there similar visceral fat depots around the neck? I know there are some brown fat deposits that have been reported around the neck area, but whether there's any specific visceral fat depot around the neck, I don't think that's also a question that's been addressed.